Our next presenter is Dr. Mohamed Ramadan, who is a pathology specialist at Research Institute of Pathology in Egypt. His presentation and comments is not always common practice. Under the supervision of Professor Dr. Shefa Khalil, research professor of pathology at Theodore Berhaz Research Institute. Mohamed, you can start sharing.
Dr. Mohamed, you can now hear my voice clearly?
Yes, I can hear you now, Doctor, but you didn't start sharing yet. Share your entire screen and then start your slideshow. Okay, that's great. I can see your presentation. Now you start the slideshow. Sorry for this disruption of the schedule. We will postpone the break after Dr. Mohamed finishes his presentation, and we will cut it in half. It will be only 5 minutes. Thank you so much. Go ahead, Dr. Mohamed.
I'm sorry for this technical issue. I am Dr. Mohamed Ramadan. I am a pathology specialist from Research Institute of Ophthalmology. I will present a case today named Common Sense is Not Always Common Practice. This case will be under supervision of our lovely Professor Dr. Shefa Khalil, Research Professor of Pathology, Theodore Berhaz Research Institute. Male patient, 64 years old, presented firstly to us by splenomegaly and abdominal pain. The patient underwent PBC and showed mild macrocytic non-Mohamed anemia, relative monocytopenia, relative leukopenia, absolute neutropenia, and mild thrombocytopenia. To conclude our available clinical data, this patient is presented to us by splenomegaly and pancytopenia. And concerning this data, we have a wide range of differential diagnosis, including hematological malignancies like leukemia, lymphoma, autoimmune conditions, myeloproliferative disorders, cirrhosis, and portal hypertension. This patient underwent a splenectomy that presented to us weighing more than 2 kilograms and showed dark, diffuse, brown, and hemorrhagic cut section. By H&E, we can show splenic tissue with a phased architecture by small and intermediate-sized cells in diffuse pattern. And also, the
Sorry, doctor, but I can't see the screen.
Is my screen is
Sorry, Doctor, your screen is shared. If anyone can see the screen, please check your connections. I can see the screen of Dr. Mohamed. Yes, it's visible to everyone else.
okay. The most affected area here is the red bulb, and it showed involvement by sheet of cells larger than lymphocytes with pale blue granular cytoplasm and rounded or folded nuclei with indistinct nucleoli. It also showed increased volume and surface and length of red bulb vessels. So we can conclude our data collected from H&E examination by 3 items. Firstly, a small and medium-sized infiltrate in diffuse pattern affecting mainly the red bulb. So our provisional diagnosis here is splenic atypical lymphoid proliferation, and surely this case will need immunophenotyping to reach our final definite diagnosis. But before we proceed to immunophenotyping panel, let's talk about what types of splenic lymphomas. Firstly, non-Hodgkin lymphoma that can include small cell lymphoma, marginal lymphoma, follicular lymphoma, and the mantle zone lymphoma. Number 2, Hodgkin lymphoma. Number 3, leukemias like hairy cell leukemia. Number 4, monoproliferative neoplasm like chronic myeloid leukemia. By H&E finding only, we can exclude or suggest some of these types. Small cell leukemia usually affects spleen in diffuse pattern and usually affecting the white blood. each of marginal lymphoma, follicular lymphoma, and mantle zone lymphoma usually affect the spleen in nodular pattern and affecting also the right bulb area. Hodgkin lymphoma usually have some large cells, especially RS cells, and affect the spleen in diffuse pattern. Leukemias like hairy cell leukemia usually affect the spleen in diffuse pattern, but it usually present firstly by pancytopenia in bone marrow. Chronic myeloid leukemia, it's a clonal granulocytic proliferation and showed leukocytosis in the TPC. Now we start our immunohistochemistry panel by CD20 that showed positive nuclear staining for the tumor cells. Another picture for CD20 with tumor cells showed positive nuclear staining. The next one is CD3 that showed negative nuclear staining of the tumor cells, but it showed scattered positive reactive T lymphocytes. PI67 showed scattered tumor cells with percentage about 5%. Tumor cells are focally positive for BCL2. To this point, we can conclude our immunophenotyping data summarized as tumor cells are positive for CD20, negative for CD3, focally positive for BCL2, and 5% of them are positive for KI67. So we here are facing a case of low-grade B-cell lymphoma or leukemia. So our differential diagnosis can be include one of the following tumors. Number 1, small lymphocytic lymphoma. Number 2, follicular lymphoma low-grade. Number 3, hairy cell leukemia. We underwent CD5 and CD23 that showed negative tumor cells, so small cell lymphoma is excluded. Then we underwent BCL6 that showed also negative staining for tumor cells, so follicular lymphoma is excluded. CD25 showed weakly positive tumor cells. Tumor cells are strongly positive for CD11C. So our final diagnosis here is hairy cell leukemia. Hairy cell leukemia, by definition, it's a rare indolent lymphoproliferative neoplasm of mature B cells. Classically, it presents by blood cytopenias, pancytopenia, and monocytopenia in bone marrow, and to a lesser extent, splenomegaly as a first presentation. It usually affects males more than females, with median age about 55. It representing 2% of leukemias in the US. On molecular basis, BRAF V600E mutation is a casual genetic event in the vast majority of hairy cell leukemias. The diagnosis is mainly done and based on peripheral blood, bone marrow morphology, flow cytometry, immunophenotyping, and immunohistochemistry and molecular studies. Thank you, Dr. Mohamed Kamail, for this opportunity, and thanks Professor Dr. Heba Khalil for your great support. Thank you.